Good afternoon, friends. Welcome back to Pediatric classes. Today, we'll discuss about allergic rhinitis MCQs, the second part of it. I hope by this time you have actually gone through the previous 5 or 6 questions we have discussed in the previous video. I hope it was useful for you. And if you have any comments or some suggestions, please put it in the chat box, okay, or in the comment section. So with this intro, we are going on directly to the allergic rhinitis part 2 MCQs. So if you have not yet subscribed to my channel, please do subscribe. So question number 7. The previous 6 questions we have discussed in the previous video. Those of them who have not gone through it, after the end of this video, you can actually see through that video. Okay. The percentage of children of allergic rhinitis having allergic conjunctivitis. You know, allergic conjunctivitis, allergic rhinitis, asthma, all these belong to a spectrum of diseases. So many times we are seeing that allergic conjunctivitis patients or allergic rhinitis patients are having allergic conjunctivitis and vice versa. So this the percentage. What is the general percentage of allergic conjunctivitis in the normal population? That is around 20%. But in a patient with allergic rhinitis, the risk of allergic conjunctivitis options are more than 30%, more than 40%, more than 60%, and more than 70%. So please take a paper, write it down, just commit. Let the answer be correct, wrong. That doesn't matter. But you need to commit. Because committing to an answer, that's the best way to learn. If you make a correct answer, that's fine. Very good. If you make a wrong answer, that doesn't matter at all. Because in life itself, we make so many mistakes and we learn from it. So this is not a very thing. So I hope by this time you have written the answer in the papers you are having in your hand. So the answer to this question is more than 70%. Question number 8, the percentage of children of allergic rhinitis having asthma. This shows that allergic rhinitis along with asthma. Okay. So please note, allergic rhinitis person having asthma, the options are 18%, 38%, 46%, and 56%. The options are, the answer is option B, that is 38%. But the converse, that is, if a child is having asthma, or the percentage of children having asthma having allergic rhinitis, that is around 70%. Okay, 78%. So that is more more common. So the percentage of children, and we are discussing why, because you need to have a general idea when you actually see in clinical practice also, or if some parents ask you, at least for percentage you should know. Because another common question we encountered in our clinical practice is one of the parent will be having allergy. Okay, so they'll say, what is whether my child can have allergy? So we should be able to say, yeah, one of the parent is having allergy, the risk is 50%. But if both the parents are having allergy, the risk is around 65%. That is different, another question. So now coming to question number 9, the best method for the detection of allergic specific IgE is option A, skin test, B, serum immunoassay for specific IgE, C, blood eosinophilia, D, nasal smear eosinophilia. And the correct answer is skin test. Skin test versus serum IgE. This is a very beautiful tabular column given in the Nelson 21st edition for the PG aspirants and those students going for exams. Please go through it. Actually, skin tests are very less expensive. Actually, the observer can see it, and they'll be more convinced. But specific IgE, the IgE is more specific, but then it is more costly. Okay, coming to question number 10. To avoid false negative skin test in a person with atopy, most sedating antihistamines should be withheld for how many? For around 3 to 4 days. Okay, and non-sedating antihistamines. When I say non-sedating antihistamine, I mean the second generation antihistamine, other things, for 5 to 7 days. Whereas Montelukast should be withheld for. This is also a practically related question, because we may have a patient on Montelukast coming to you and you are prescribing a skin test result, but make sure that you need to stop the Montelukast for options A, 1 day, B, 3 days, C, 7 days, and D, 14 days. And the correct answer is option A, that is 1 day. So Montelukast needs to be stopped for 1 day. Suppose the patient is taking some sedating antihistamines like cetirizine and all, they should be withheld for 3 to 4 days, and non-sedating ones, they should be withheld for around 5 to 7 days. Now, Now we are going on to the treatment aspects of it. Okay. So what is the main differentiating item between an intermittent and persistent allergic rhinitis? So before discussing this question, I will go on to this classification. Okay. So what is this area classification? Area is like the global allergic rhinitis and its impact on asthma. That area classification of ARs is there are two types. Okay. One we have classifying as intermittent and persistent depending upon the number of symptoms the person is having. That is like intermittent means less than 4 days a week or less than 4 consecutive weeks at a time. And persistent means more than 4 days a week or more than 4 weeks at consecutive weeks at a time. And please note, this is one way. And another thing is we need to also tell the patient whether having mild or moderate to severe rhinitis. Okay, mild and moderate. How can we differentiate? This is based on these 4 criteria. That is, if the person is having normal sleep, normal daily activities, normal work and school, and no troublesome symptoms, the patient comes under mild category. Okay, and but they're having symptoms less than 4 days, means it will be mild intermittent. Same category, but the patient is having more than 4 days a week. The patient is having symptoms, means it will be mild persistent. Okay, and what about this moderate to severe? How can you remember all this? See, if you have a good night's sleep, what will happen generally? The next day will be having a very good daily activity. There is no troublesome symptoms. We'll have a good work and normal work and school and all. So this criteria, but whereas in a moderate to severe criteria, what happens, or severe AR, they have an abnormal sleep, they have an impairment of daily activities, they have difficulties at school or work, and they have troublesome symptoms. So this is also important. So this category of allergic rhinitis, we need to actually consider the number of times the patient is having symptoms, and also we have to categorize the symptoms according to the sleep or daily activities and the other things which I have discussed so far. So we have 4 types of AR. That is, one is mild intermittent, the thing is mild persistent, the third one is moderate to severe intermittent, and moderate to severe persistent. Okay, now with this, can we go back to this question? The main differentiating item between intermittent and persistent AR is A, sleep pattern, B, number of attacks per week, C, daily activities, and D, troublesome symptoms. And I am sure you are clear with the answer here. The choice is none other than option B, that is number of attacks per week. So intermittent will have less than 4 days a week. Symptoms will be less than 4 days a week or less than 4 consecutive weeks at a time. Now, this is another question. A 7-year-old male child having nasal stuffiness and running nose most of the days of the week. Teachers, there are no other. Please note, their child is not having fever, child is not having any cough and all. The child is also told the child is sleepy most of the time in the class. Which category of AR does the child belong to? So with this question, we have to actually analyze it. As I discussed now, we need to know whether it is mild or moderate to severe. We need to know whether it is intermittent or persistent. So child is having symptoms most of the days of the week. That shows that most of the days of the week the child is having symptoms, then it will come under persistent category. And the child is sleepy in the class, and now that shows that the sleep is not proper at night. So the child is having not a normal daily activities. So that shows that the child is having a moderate to severe AR. So what is the diagnosis? The diagnosis is moderate to severe persistent AR. That is option number D. Okay. Now, what is the treatment option in the previous case? Options A, first generation antihistamine. Option B, intranasal decongestants. Option C, leukotriene antagonist. And option D, intranasal steroids. So we have discussed so far that the child is having a moderate to severe persistent AR. So first generation antihistamine is generally given for mild intermittent types. Okay, what is the difference between first generation antihistamine and second generation? You already know. That is about the sedating properties. Okay, the first generation is more sedating than the second generation. Or intranasal decongestant, like your oxymetazoline and sprays and all. But that also we cannot use, are not recommended for moderate to severe persistent types. Okay, leukotriene antagonists like montelukast, or is it intranasal steroids? The answer is option D. That is, intranasal steroids are the treatment of choice in a case of moderate to severe persistent AR. Okay, so this is the way you should analyze a patient coming to the OPD. We can actually categorize whether it is mild or moderate to severe. Then we need to categorize whether the child is an intermittent or persistent case. Then we finally write the diagnosis of AR is mild persistent or moderate severe persistent or mild intermittent or moderate to severe intermittent, and accordingly you can actually decide on the treatment options. Okay. Question number, no, I'm not going to discuss further questions now. So we'll discuss about some other topics some other day, because I wanted to keep it very short so that you can just go through it in a few minutes of time. Okay, thank you so much, and see you guys all. Stay safe. Bye.